Okay. Thank you. Good evening once again, everyone. David, I think you are recording this.
Yes.
This was the case that I saw, I think, 2 weeks ago in my outpatient clinic, and I think everyone will benefit from it because there is some learning from it. And this was a 71-year-old female who presented in the OPD complaining of palpitations.
Okay. So, an interesting complaint that I believe many of us encountered at some point, and uh, it's not I shouldn't say surprising, but then I cannot recall if I have a very well organized schema when it comes to palpitations. But then, when someone comes, and of course patients will tell you that I feel my heart racing, or we frame it as awareness of heartbeat, or any other terms that we use. And there's a number of things that come to mind quickly when you hear about palpitations. This is a 71 years old female who presents with palpitations, and therefore uh, maybe one way to approach this would be, and as I said, I do not I do not remember if I have any particular schema uh, for dealing with palpitations in a systematic way. But someone who presents with palpitations, there is a number of possibilities. So maybe if we go in terms of organ systems, of course, the cardiovascular system is a possibility in a number of patients. And one way would be to think about, you can try and adapt the schema that is used for syncope, for example, and that can take you somewhere when you think about palpitations. So, for example, uh, someone who has, I mean, it can be the problem with the pump itself, which is the heart. Can be the problem. It can be a problem with the pipes, that is the blood vessels, and then it can also be a problem with the fluid, which is the blood. So, for example, uh, palpitations are a common presentation of cardiac arrhythmias. So many sorts of cardiac arrhythmias that you can think about, and especially the common ones like atrial fibrillation, for example. But then uh, so many cardiac arrhythmias will present with palpitations, and therefore, one clarifying question that I'll ask, of course, uh, uh, on top of expanding the complaint of palpitations in general, but I'll ask what exactly the patient is feeling. Are they feeling their heart racing, or are they feeling their heart to be slower than usual? Because both of them will present with palpitations, tachycardia or bradycardia, because the way I interpret palpitations is simply awareness of heartbeat, and therefore uh, it can either be tachycardia or bradycardia. And another thing is, if whether they are feeling their heart racing or slower than usual, whether they feel it to be regular or they feel any skipped beats, and therefore that may not be very sensitive, because patients do not may not be observing all the time what exactly is going on. But if you get those pieces of information, they can be helpful in making some progress. So cardiac arrhythmias are one of those things that I think about. And then when it comes to problems with the pipes that I talked about, so if someone has hypotension due to anything, one of them being, so for example, if someone has vasodilatation caused by anything, they will have palpitations, because when there is a reduction in end organ perfusion, definitely the heart will try to compensate by pumping faster. in order to make sure that perfusion is maintained. And then problems with the fluid itself. If someone has had diarrhea, for example, or excessive vomiting or acute blood loss, either due to trauma or anything that leads to bleeding and therefore blood loss, they will compensate for the reduction in effective circulating volume by pumping faster. And so these are also possibilities. So that is an adaptation of syncope. When you think about syncope, palpitations can be exactly the same way. But then, if you just stick on that, you might miss a number of other differentials. So to be specific, anemia in particular goes in here. But then we should not forget some endocrine causes which can present with palpitations. So, for example, someone with hyperthyroidism will present with palpitations as one of the complaints. But another one is glucose. So, for example, hypoglycemia, one of the sympathetic presentation of sympathetic symptoms of hypoglycemia is palpitations. And then remaining in the territory of endocrine causes, you talk of things like pheochromocytoma, which is very rare, but then episodes of palpitations in association with other symptoms like headache, and then diaphoresis, as well as episodic rises in blood pressure. So palpitations, I should just say that it's a very broad complaint, very non-specific, and therefore to be able to put your foot in one place, you need to see some associated symptoms which can help you narrow down in a particular organ system. Because again, I did not discuss some purely neurological issues which can present with palpitations, including some neuropathies which do present with uh, autonomic dysfunction of some sort, leading to palpitations. So there's the list of differentials is very broad. So let's just see the HPI, and then I think I'll make some progress.
Okay, thank you. That's a pretty good start. Yeah, so she reports that 4 days ago she noticed her heart was fluttering. She also noticed that the fluttering increased with exertion. She has a blood pressure machine at home, so she kept measuring her blood pressure at home multiple times, which was normal, but her heart rate kept varying between 40 to 124. And she said this is not her usual heart rate. Her usual heart rate will be around 70. Um, so the next day, she noticed her heart was racing even with minimal activity, like walking to a bathroom. And on the day before admission, the day before presentation to the clinic, she noticed she was getting short of breath with exertion. But there was no shortness of breath at rest. There was no chest pain. She denied cough, fever, sore throat, nasal congestion, melena, abdominal pain, nausea, vomiting, diarrhea, dizziness, or altered mentation. To you, David.
Yeah.
Oh, sorry. I think I should go on because to be a long case. Unless yes, let's complete this. There's nothing important. The view of other system was non-contributory. Past medical history: she has diabetes for 22 years. Initially, she was on oral hypoglycemic, but there was poor control. We transitioned her to insulin 6 months ago. Her current A1C, which was done 2 weeks ago, is 10%. She also has diabetic neuropathy and glaucoma. She's on meds, including insulin glargine, which she injects once daily, and Atrapid, which injects around meals. She's also on pregabalin, Neuroton, and eye drops, 3 types: timolol, latanoprost, and dorzolamide. Family and social history: she has multiple first-degree relatives with diabetes. She's a non-smoker. She's a non-drinker. She's very active when she's normal. She has a bicycle machine at home that she will ride like every day. Yeah, so let's discuss all of this.
Yeah, this is a packed history, although it's just some two slides, but then very packed. So as I said earlier, I see some light coming up. So the patient reports fluttering, and the good a good thing about this patient is she seems to be very informed about her illnesses in general. She monitors her blood pressures at home, and she can even report. She can even report her heart, the pulse rates that she was recording. So this was a good day for you because at least she reduces the burden to the physician. So a lot of variation in her pulse rates as recorded by the BP machine between 40, which is 40 is bradycardia, and then 120, and of course the bradycardia, because so the normals that we claim in medical school is that a normal heart rate is between 60 and 100 beats per minute, although some will tell you that a resting heart rate of more than 90, that is already tachycardia, but then the usual cutoffs that we use are between 60 and 100. So, but then something below 60 does not really mean it's clinically important. If you find someone with the pulse rate of 50 something, 56, 58, they do not have any symptoms, it's not really significant, because someone will have bradycardia due to conditioning. So for example, people who are very athletic, they have resting bradycardia, so that would not be an issue. But then bradycardia that causes symptoms to make someone to be aware of their heartbeat, uh, that warrants consideration. So very varying between 40 to 120, and what she reports is fluttering, and then it happens, the heart is racing even with minimal activity. And then one day before admission, she notes that she's becoming short of breath with exertion. So we see some accompanying symptoms that are coming up here. So apart from the so basically this wide variation that we see, I think makes me think about focusing particularly on the heart. But then we know, especially when you are talking about arrhythmias, it can just be a primary problem with the heart, that is, there is nothing else that is triggering them. Maybe these, so for example, if you talk of atrial fibrillation, there is a number of risk factors. You talk of hypertension, diabetes itself, someone who is smoking, overweight and obesity, you have valvular diseases, and a number of other things. But then you can have arrhythmias which are triggered by things that are outside the heart. So, for example, when you have electrolyte abnormalities, acid base abnormalities, and many other things, they can trigger arrhythmias. But then the palpitations that we are talking about, uh, I think this may be very early to say that it's predominantly uh, localized to the heart, because there's a number of other things that are coming up. But then we see some secondary presentation is that whatever is going on, we see symptoms apart from the palpitations, the awareness itself. Uh, it progressed to cause difficulty in breathing on exertion. And initially, it seems as if exertion is triggering these palpitations. Can I see the next slide? Yeah, so no shortness of breath at rest, and then we talked of some other symptoms or other organ system involvement that can present with palpitation. So for example, no melena, if someone is losing blood in the GI, for example, and then vomiting, diarrhea, low, a reduced effective circulating volume depletion, and then an issue of dizziness. which I think I'll discuss together with the history of diabetes. This is a patient who has diabetes for more than 22 years. She's a 72 years old female. So that means this diabetes was diagnosed around the age of 50. Yeah, around 50. So she has lived with this diabetes for more than 22 years now. Because I talked about some neurological abnormalities or some neuropathies to be specific, which can present with palpitations. But then diabetic neuropathy, when you talk of diabetic autonomic neuropathy, a good way to distinguish it with volume depletion is that diabetic neuropathy predominantly, so someone will present with orthostatic hypotension. So when they rise up from a sitting position, for example, or they rise to sit from a recumbent position, they experience dizziness. But then with diabetic autonomic neuropathy, commonly that dizziness is not accompanied by an elevation or by an increase in heart rate, because so commonly the the baroreceptor mechanisms of the body are impaired, and therefore they experience dizziness, which is due to impaired perfusion in the brain. But then the baroreceptors, including the carotid body and other baroreceptors, which are sensing that the pressure is low, and therefore let's deploy some quick mechanisms to restore perfusion, particularly by increasing the heart rate and cardiac output in general. They are impaired, and therefore these patients will present with dizziness, but then you do not see an appreciable increase in the heart rate. And therefore, what is going on in this patient? Of course, there could be another sort of autonomic neuropathy in this patient that is presenting this way, but then diabetic autonomic neuropathy predominantly would not cause this marked increase in heart rate, and therefore that makes me think of it less likely in this patient. Can I see those other slides? Yeah. So review of systems and remarkable. The diabetes is uncontrolled with a glycated hemoglobin of 10. So a target is, if the patient is not having many comorbidities, we would like to take this glycated hemoglobin to below 7. This is 10. So basically uncontrolled diabetes, and she has diabetic neuropathy, which I've already discussed about with regards to the presentation of palpitations. Another issue is she's on insulin. So episodes of hypoglycemia can present with palpitations. And again, patients with uncontrolled diabetes and diabetic polyneuropathy, autonomic neuropathy can be part of that story. And therefore, these are patients who can have episodes of hypoglycemia without awareness. But then, so commonly we expect hypoglycemia to also come, apart from palpitations, to also come with some other accompanying symptoms. So there are neuroglycopenic symptoms, and there are the autonomic symptoms, including the palpitations. So neuroglycopenic symptoms are like, for example, someone experiences a low level of attention or disorientation, and that can go to confusion. You can even ask them what is their name, and they do not remember. And so the part of the autonomic symptoms would be the palpitations, sweating, tremors, which we do not see in this patient. But then, as I said, a patient with hypoglycemia and diabetes, which is uncontrolled with diabetic neuropathy, may have episodes of hypoglycemia without awareness. But then maybe it's not a very likely thing here, because we do not see that in this patient, and we see that the episodes are ranging, the palpitations are ranging from bradycardia going as low as 40, and then tachycardia as high as 124, and then they seem to be precipitated by physical activity, which again can be indirectly connected to hypoglycemia, but not very likely. So another thing, in the family social history, we do not see other risk factors. So there's a very strong family history of diabetes, but then this patient does not smoke, does not drink. We know that these are some of those things that can trigger arrhythmias. As I said, smoking is a risk factor for atrial fibrillation, for example. And then drinking, yes, some people get palpitations after they have a drink. And then, of course, another thing is important to ask about, if these patients takes caffeinated drinks and whether they precipitate the palpitations. uh, yeah, so I think those are my thoughts for now. Maybe Joseph, if there is any part of the history that I did not touch on, you can remind me, but otherwise let's proceed to physical exam.
Yeah, thank you. So she doesn't take caffeine. Let's see the physical exam. She was alert and oriented. On that day, she was on wheelchair. So she attends diabetes clinic on my clinic, and she usually comes walking, climbing the stairs. But on that day, she said she was too tired to climb the stairs, so she um, begged the porters to put her on wheelchair, and so she came on wheelchair. She was not in distress. She was a febrile, not jaundice. She had bilateral pitting lower limb edema. She didn't have lymphadenopathy, peripheral. A vital sign, she had a blood pressure of 142/86, a pulse rate of 76, respiratory rate of 22, temperature 37. So starting between 92 to 95 on room air. Cardiovascular exam, regular rate and rhythm, S1 and S2 ahead. There was no murmur. Respiratory system, respiratory rate was 22. The chest was clear to auscultation bilaterally. My limited chest exam on the clinic. For abdomen, the abdomen was non-distended and non-tender. Neuro exam was also normal. And that's the exam.
Okay, let's start from the general exam. Yeah, so alert and oriented, and then, so again, from the history, we had that when the patient is exerted, she becomes dyspneic, and as it seems, exertion also precipitates these palpitations. So we come to physical examination. Uh, we see that there is a bilateral pitting lower limb edema. Now, we do not know when the patient last attended this clinic, but if this is a new finding, and in the history, we did not hear at least some features that are pointing us in the direction, I would say major criteria for heart failure, like if the patient has orthopnea, PND, uh, but then we see lower limb edema here. Now, if this lower limb edema has come very very recently, of course we'll investigate further and see, because there is a myriad causes of lower limb edema, but the heart is one of those. No lymphadenopathy. So the patient is hypertensive. I do not remember in the history hearing that this patient has hypertension and whether she's on any antihypertensive medications, but here she's hypertensive. The pulse rate 76, which is within the 60 to 100 that I talked about, but she's tachypnic at 22. And then this saturation between 92 to 95. Of course, I know that in our setting, someone with an oxygen saturation of 92, maybe people will not be very worried to give oxygen. But then, uh, so basically, we see I should say, some relative hypoxemia here, and we need to see what exactly is causing this. When we come to systemic examination, the heart that we are very much curious about, we see that there is a regular rate and rhythm. So basically, uh, whatever we are talking about, if it's an arrhythmia or anything, and of course I kept talking about arrhythmias, but another issue is conduction abnormalities. So you can have uh, you can have bradycardia or tachycardia from conduction abnormalities. So from heart blocks, pre-excitation syndromes, and many other things. So we hear the rate is regular. I mean the rhythm is so she has a regular rate and rhythm, which is not a finding that you pick in a patient with atrial fibrillation, for example. But one thing that we should remember is that the arrhythmias or anything that we are talking about that is coming out of the heart can be episodic. So, for example, premature ventricular complexes or premature ventricular complexes, which can also present with fluttering, may not be happening all the time. Atrial fibrillation can be paroxysmal AF, and many other arrhythmias can be episodic, and therefore not picking abnormalities as of current does not mean that this patient has no problem. And then no mammals, we talked about valvular disease as one of risk factors for atrial fibrillation, for example. We are told no mammals here, although yes, definitely this is a patient who will need an ECG and an echo. So we'll see. So tachypnea 22, but then the lungs are clear to auscultation bilaterally. Nothing that we pick out of the lungs. We saw an oxygen saturation of 92 to 95, but then we are not hearing any crackles. So, for example, if we are talking about heart failure in this patient with lower limb edema, and then she's presenting with dyspnea on exertion, if there was pulmonary edema, for example, that would be picked as basal crackles, which we do not hear in this patient. Abdominal examination unremarkable. Neurological examination also unremarkable. I'm not sure if Joseph that includes sensory examination like joint position sense, uh, vibration, and touch, as well as pinprick sensation, which are important in this patient with diabetes in order to tell if there is a sensory neuropathy, which could be an early presentation in a patient with diabetic polyneuropathy. So we do not see sensory examination in this. So Joseph, if you did that, you can tell us. But otherwise, what I see is that the physical examination is very unrevealing, and maybe another thing would be interesting to know the hydration status of the patient, because volume depletion can present with palpitations, but then right from the history that didn't seem to be the case, although I think it's very important just to be sure. So Joseph, if you have the details of those, and then we can proceed to investigations.
Yeah, I can say hydration status had moist mucous membranes, but yeah, neuro exam, I didn't do the sensor, these clinics, busy clinics, and it's objective, like there is nothing about weakness or sensory, and then keep it out. I didn't do that, but past medical history, she has the peripheral neuropathy, as I said. Did I proceed?
Yeah, let's hear the investigations.
Yeah, yeah. So here are the investigations, and white count was 5. She had an HB of 10.6. Looking back, this is usually high HB around this. Platelet 169, creatine BUN within normal limits. Liver enzymes also within normal limits. She had an RBG of 16, which was raised. Malaria was negative. She had a TSH of 2.3, which was also normal. Yeah.
Yeah, so let's so starting from here, I think a number of things can be excluded or ruled in or ruled out from here. One cause of palpitations that we are talking about is anemia. An anemia of 10, you you do not really expect someone to present with palpitations with a hemoglobin of 10. Therefore, yes, the patient is anemic, but this does not explain this dramatic presentation. So yes, it can be, I mean, compounding it, but then an anemia of 10, this patient's oxygen carrying capacity is apparently adequate to explain the palpitations. Another important thing is the thyroid, which when I was discussing some endocrine causes, I talked about the thyroid. So the TSH is within normal limits, and if the cutoffs for T3 and T4 that you are using are the same as the ones that I have in mind, even the T4 and T3 are within normal limits. So basically, hyperthyroidism is out of question, and hypothyroidism also, because hypothyroidism can present with bradycardia, hyperthyroidism presents with palpitations and can trigger arrhythmia. So thyroid abnormality is out of question. An RBG 16. So 16 now is hyperglycemia, but then you know blood glucose is not a static thing; it's dynamic, and therefore uh, this patient could still be experiencing, although from the history, it's not very telling that this is hypoglycemia, for example. But then we cannot completely throw out hypoglycemia as a cause of, or, or at least precipitating the palpitations in this patient just because of an RBG of 16. So, but then as of current, when this patient is being seen, and when these labs are ordered, I believe this was a time when she was not reporting the palpitations. The pulse rate was 76. The rhythm, so she had a regular rate and rhythm, and the blood glucose is 16. So at this point, again, no hypoglycemia to explain palpitations as part of the autonomic presentation of hypoglycemia. So these labs are excluding a number of things: anemia, excluding hypoglycemia at this particular point, but not throughout when she's experiencing these episodes, and then it rules out objectively, and I should say completely, thyroid abnormalities, whether hyperthyroidism or hypothyroidism, because of this normal TSH as well as T3 and T4. So let's proceed.
Yeah, thank you very much. And now the interesting part. So I ordered troponin, it was 0. And I forgot to put it here, but I also did ECG and the echo. The echo was normal. The ejection fraction was 65, and nothing abnormal. And I ordered also ECG. So what you're seeing here is the very fortunate. This patient 2 weeks ago, she underwent like a routine checkup at another hospital. When I ordered the ECG, she also told me I've already done that 2 weeks ago. I said, okay, good, I want to see it. This was the ECG done 2 weeks ago, and the ECG on the day of when I was seeing the patient with the complaints is this one. So I think you can compare. You can start looking at this, and then you will tell me if you're done with this. I will show you the ECG on the day of admission to the patient, if there is anything.
Yeah, so I'm trying to zoom it out here. Let me start with this initial ECG here. I'll just be quick in order to save time. So starting with, I'll start whether it's sinus or not. I'll try to go quickly, but I'll go back to the basics. So quick looking here, I see that this is, well, it's sinus, because you can see that every QRS complex is preceded by a P wave. So this is sinus rhythm, and it looks regular to me. It looks regular, and the heart rate I see, the approximately one, two, three, four, about four large boxes. Four large boxes, that translates to about 20 small boxes. And if I take 1500 divided by 20, that's approximately 75. So the heart rate is around 70, 75. And because this patient presented with palpitations, I think those will be things that I'm interested to look at. I see P waves, and therefore you see P waves, you cannot talk about atrial fibrillation. The rhythm is regular. It's not something that you see in atrial fibrillation. For example, you see irregular RR intervals, which we do not see on this ECG. And then the PRI interval is also something to see. The PRI interval in this patient is more than three small boxes, but less than five small boxes. So basically, again, the PRI interval normal. That's also for me quickly to look at. It's important because there are pre-excitation syndromes which can present with the short PRI interval. But again, I talked about conduction abnormalities like heart block, which can present with bradycardia as part of their presentation. Would expect a prolonged PRI interval, which we do not see in this patient. And then the T wave, the T wave morphology as well as orientation, I see them to be normal. So basically, uh, a quick look at this patient. With regards to the palpitations, I do not see anything dramatic. So let's can I see the next one for comparison?
Yeah.
Okay, this one. Okay, I'll try to zoom it out again. Yeah, so when I zoom out, I see my resolution gets worse. But
Should I zoom it for you?
yeah,
Like,
yeah. Can you try to zoom it out from there?
is it working if I do? I'm zooming it.
Yeah, yeah. I
So I'll do this and
And then you can be moving it.
oh,
Okay, so uh, again, let me see some. I'll also try to be quick here. Uh, so I'll start with. Yeah, let me see. Let me see who is unmuted to. Okay. Yeah. So again, quickly to see whether this is sinus or not. I'll start here. Your lead two is hidden above there. I cannot. Is it because you zoomed it in? Yes. So there is lead two. I'll start here again. This is sinus. This is sinus, as you can see that we see a P wave for every QRS complex that we see. Maybe too early to say for every, but I see P waves here, and so this looks sinus. I'll start with lead two here. I see a P wave here. I see another. Joseph, are you also moving from there? Because when I try to zoom out and try to settle, I see it blurs and comes back. But then so I see P waves, But then coming to the rhythm, whether this is regular or not, uh, because of the resolution, it's not clear whether, let me see the small boxes, but this looks, these are two, and then maybe four small boxes here, three small boxes here. Yeah, so when it comes to the rhythm, because those are important things that I look at initially, whether this is a regular rhythm. So the whether this is sinus, I see P waves there, and I also see uh, it looks regular. Then I'm coming to the PRI interval. The PRI interval looks, yeah, it's the PRI interval is a quick look. Looks like it's within normal limits. But then some quick pathology is not to waste a lot of time here. Joseph, if I miss some things, you will tell me. So things that I see quickly here is that if the leads are properly connected, you see the T wave inversions. There are T
Mm.
wave inversions that we see on. It's normal to have a downward looking T wave on V1, but then we see that on V2, on V3, V4, as well as V5, and maybe V6, although it gets small as you go lower. But then, so in these precordial leads, we see T wave inversion in most of these, from V2 almost all the way to V6. So it's the T wave inversion that I see there. And then now, is there an ST segment, ST segment abnormality anywhere? When I look at V1, I do not see that. V2 and V3, it's a slight depression. So when I look at the equipoint, but then because I cannot see the small boxes, it's hard to tell how many boxes. But then I see like V2, V3, there's a slight ST segment. The J point looks lower than it's supposed to be. So that is particularly for V2 and V3. V4, V5, and V6, I do not see an abnormality of the ST segment. So, and when I go territory by territory now, uh, Joseph, can you zoom it out, reduce the size so I can see lead one, and I can see lead one and lead two? Yes. Yeah. So when I go territory by territory, is that when I start with the left-sided leads, I do not see these obvious abnormalities that I talked about. So in lead one, AVL, especially with regards to the ST, and then V5, V6, the right-sided leads, uh, lead 2, lead 3, I mean the inferior leads, lead 2, lead 3, as well as AVF, I do not see those abnormalities. So predominantly, I saw that on V3, V4, I mean V2, V3, but then the T wave inversion, I see that was more widespread. It's not limited to V2 and V3, where I talked about the ST segment, the slight ST segment depression that I see. The T wave inversion is, I see that on V2, V3, as well as V4, V5 probably. So quick, if I'm missing anything, Joseph, you'll tell me. But what I see is that the rhythm looks sinus, and it looks regular from this side. The PRI interval also looks normal. And then, so the quick abnormalities that I see are the T wave inversions in the leads I talked about, and the ST segment depression, especially on V2 and V6, which I'm not sure if it's more than two small boxes, if it's significant. Yeah, so that's what I see, Joseph. If there is anything that I'm missing, just point it out to me. Was the
Yeah, I think it's the same. And the most remarkable thing is saying you saw the this one 2 weeks ago completely normal, and this one the same thing that you're saying. T-wave inversion in those leads that you're talking about. That's also what I also saw. Are we proceeding from here?
Okay, so the ST that I'm talking about, is it? Did you see that, and was it significant,
No, I
or
took
is
my
it?
ruler.
Yeah.
I took a ruler, and that there was no ST changes.
Okay. 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 Let's proceed, and then if there is anything, I'll need to come back to this. Yeah. So
Yeah.
so a chest X-ray here. What I see quickly uh, is yeah, is this infiltrate that you see, and it's predominantly perihilar. So again, I'll go quickly here, and you tell me if there is anything that I'm missing here. But this is not very typical, but then close to the batwing appearance that we talk about, and therefore pulmonary edema is among the differentials here. We see this these perihilar opacities here, and when we come to the angles, particularly the costophrenic angles are not very well. They do not seem to be obliterated, but because the opacities are extending all the way to where the particularly the costophrenic angles are, they do not look very sharp, but it doesn't seem like a pleural effusion for me. So it's the perihilar opacities that I see, and one of the quick differentials here is pulmonary edema. uh, I mean, putting together the presentation of this patient, although other things like not very typical of the but a bilateral appearance like this one. Uh, Again, their typical pneumonias can present this way, but then telling the findings and putting them together, I think pulmonary edema is one of the possibilities here. So the formal report, Joseph, if there was anything that I'm missing from here.
Yeah, so actually there is no formal report, and slightly different from yours, but yes, this is definitely an opacity. This one, as you're saying, I hardly see anything out there, but yeah, it's okay for you. Yeah, should we proceed because we're out of time?
Yeah, yeah. Let's proceed.
Yeah, so at the moment, I think if you have a diagnosis, you can keep it up.
Well, so a diagnosis at this point, I'm struggling to make a diagnosis, but I think what I'll try to do in order to make progress for this patient is that I saw some abnormalities on the ECG that you did, and if you compare that to a previous ECG, and the things that we saw were the T wave inversions, which were more widespread. So to make a conclusion that it involves a particular territory, but then V2, V3, V4, and that was where. So if we talk about a particular territory, we will say more anteroceptor. We see T wave inversion, and therefore, of course, T wave inversions can come due to many things. So uh, one of the things that I'll need to investigate this patient very meticulously for is that we should not miss coronary artery disease. Although, yeah, Joseph told us that you did troponin, and it was zero, but So troponin basically is when there is when you talk about if you take an example of so for example now we are I shouldn't say that and of course this patient could so coronary artery disease I think is one of those things that I'm very worried about in this patient because of because of those abnormalities that I saw, which do not strictly obey a particular territory, but then those T wave abnormalities that we saw, I think, and yeah, I do not think that I looked. I tried to look very closely, particularly at the Q waves, in order to see if there were any pathological Q waves anywhere. But I think coronary artery disease is one of those things that I'll make every effort to see if there is anything. So Joseph, you are telling us that an echo was done. So what we expect is that if there is a significant coronary artery disease, we might pick regional wall motion abnormalities on echo, which I'm not sure because you did not include the report here. And if I recall correctly, you say that there was normal the EF, and so I believe maybe no regional motion abnormalities were picked. But then I think further investigation for coronary artery disease is very important in this patient. Now, how is progress made? Because if we did troponins, they are low, and I mean they are within normal limits, and so we expect troponins to be elevated when you talk of there is a myocardial injury, so particularly when there is a myocardial infarction. So in something like unstable angina, for example, uh, these patients do not present with elevated troponins, but then you have the symptoms and you have the ST changes. So the palpitations, and yes, when you have ischemic heart disease can trigger arrhythmias. Ischemic heart disease can trigger arrhythmias, and therefore, and we saw that what was very telling for this patient is that when she was exerted, initially she reported like a worsening in the palpitations, and then she started becoming dyspneic on exertion. So we see dyspnea on exertion. We do not hear chest pain. So for this patient, I think because of the long-standing history of diabetes for more than 22 years, and the diabetes is uncontrolled, uh, and she has diabetic neuropathy, at least from the history. Now she's presenting with exertional dyspnea, but exertional dyspnea comes after she had a few days history of palpitations. So I'm thinking ischemic heart disease as one of the differentials that will be on top of my list, because ischemic heart disease explains the exertional dyspnea, which is an angina equivalent, and we may not look into into um, so it's an angina equivalent because this patient is diabetic, and therefore uh, expecting the patient to present with angina or chest pain may be an issue, because if the patient is having autonomic neuropathy, they may not even be able to pick the pain. So being female, having diabetes, the exertional dyspnea should be counted as an angina equivalent, and therefore the changes that I see also are concerning for ischemic heart disease, and therefore I think so. What I would do, and this may not be exactly in keeping with the guidelines, but I think I'll investigate this patient further in the line of ischemic heart disease. And yes, as Fabian, I saw some things here in order to pick the arrhythmias, in order to pick if they are paroxysmal arrhythmias. Definitely, Holter is important, but So we could have differences in how we approach this, and maybe cardiologists can do a better job. But then, yeah, if you do stress ECG, for example, uh, the the ischemic changes, if any, will be more apparent. But we are seeing some changes here, and therefore, I think for me, I'll just refer this patient for further workups with regards to ischemic heart disease, and then of course Holter is important in order to see. But so one theory that I have is that it's the ischemic changes that are happening are what are also triggering the palpitations that we see, maybe some arrhythmias which are triggered by ischemia. So that is a theory that I have. I'm putting ischemic heart disease on top of my list of differentials, and of course we'll need Holter ECG to see if there are any arrhythmias that we are missing. But then my theory is the arrhythmias are triggered by ischemic changes, although they could be separate diseases, and that is where I would. But either way, ischemic heart disease and arrhythmias, I think those are my top on the list. But I'm thinking that ischemic heart disease is the cause of everything. So that is my working theory, Joseph. I think I've already taken enough time. Just take us home, and I'll sit back and learn where I missed any issues.
Yeah, thank you very much, David. And I think you've elucidated a lot of things there. And this also was a tough case as even to me. And thank you also, Fabian, for the comment that everyone else. So, I know this patient. And when I saw her, I realized patient is sick. It's not the way I used to know her. So I realized as you talk, maybe MI and some stuff. But the negative troponin, I said, no way. And no ST changes in the ECG. And the very important thing, the crucial thing that led me to the diagnosis is the ECG that she did 2 weeks ago. And for me, I said, okay, if there is anything else, I will send the patient to JKCI, but let me rule out pulmonary embolism. And what you're seeing here, that history, shortness of breath with exertion, palpitation, acuity of onset of the disease, with the ECG, with which only T wave changes on the anteroceptor, the right ventricle part. I said we should rule out PE. What you're seeing here is the screenshot of the pulmonary trunk. This is the main. And one important thing, also, this will be a teaching point. If you're in a center with which can perform CT pulmonary angio, learn to recognize some sort of PE, because what I realize sometimes the radiologist is not there. You expect a report later, but you have to treat it now. And it's not difficult the way I learned it, and I'll teach you some. So what you're seeing here is the main pulmonary trunk. You go this way, this is the right pulmonary artery, and this way, are you seeing my cursor? I think this is the left pulmonary artery, and some others which are not important, like this one here is the ascending aorta, the descending aorta, the right bronchus, left bronchus, esophagus. Yeah. So the important thing is this T-shaped thing. So you scroll and follow it. You start with the main pulmonary artery, you follow it, you realize there is nothing. So to be quick, let's go on the right pulmonary artery. So it's okay until here when you see a blackish thing. So this is suspicious. This is a PE. This is what the radiologists say. I think they use a word. There is okay, I don't know what the word they
Feeling
use, but
defect.
yes, the feeding defect. So you see here, this is a PE, definitely. So when we saw this, say we should treat this patient as PE and wait for the radiologist report. And yes, the radiologist also said this is the PE. So David, when I saw this is a PE, I say, okay, what we saw on the ECG after 2 weeks was the right heart strain, and I had to go back again to that ECG. And let me show you some interesting thing. You see this ECG here. You realize, look at this. let's say you're finding that S1Q3T3, which is everyone learns, but we never see it. Uh, S wave in the lead one, oh, uh, not much, not much. And then lead three, the Q wave is there, but not much, and the T is normal. But here there is an S wave. QRS is deeper than the ECG she did 2 weeks ago. And in the read 3, this Q wave is pretty prominent compared to that ECG. And there is a T wave inversion. So after I saw that this must be PE, go back, I realized also there is S1Q3T3 plus right heart strain, isolated T wave inversions in the anteroseptal leads. Yeah, so it was a case of PE that it's so hard. Maybe I could have missed it, but I caught it. And the final diagnosis now was right pulmonary embolism. We started the patient on enoxaparin at 1 milligram per kg BID, and then we transitioned her to rivaroxaban 15 milligram BID for 21 days, which she's on right now. Then we put her on 20 milligram for life because this is so unprovoked. There is no any provoking factor here. So when we gave this enoxaparin on the second day, all the symptoms disappear. The patient could walk to the bathroom, no shortness of breath, no palpitation, nothing. So we realized we've treated the disease. Because of time, few teaching points. Palpitation are common in PE, and they can be because of arrhythmia. As the thrombus is passing through the heart, it can trigger some arrhythmia. Maybe if we put ECG on the time that she had a 40 or 124, we could have seen some arrhythmia. But also it can be just a sinus tachycardia, which is the most common presentation with the on the ECG, for example, in PE. But I use this case to remind myself of ECG changes in PE, which are common, but they are not specific. Anything can be there. So you can see sinus tachycardia, which is most common. You can see a right bundle branch broke, complete or incomplete. You can see a right ventricular strain, inverted T wave in V1 to V4. You can also have this S1Q3T3, which everyone knows, but it's only present in 20% of patients with PE. You can also see right axis deviation and non-specific STNT changes. Also, the chest X-ray, there was something there, but yeah, usual. When you do chest X-ray for something else, but you see stuff, and they are non-specific. Even if we saw like effusion, no problem. It is non-specific. There will be anything there. But the chest X is usually normal in up to 22% of cases. The things that we learn in theory, like Hampton hump, Westermarck sign, Parler sign, or Freischner, these are very rare. But if you see them, be very suspicious for PE. The one that we saw, I think it doesn't fit with any of these. It was a non-specific change. Yeah. And one thing, in the institutions that I've worked personally, where there is a CTPA, I'm known for sending CTPA, but it comes negative. And for me, that's okay, because if you miss PE, patient might die. But just send it. If you catch it, you treat the patient, and from my experience, it's very treatable. If you treat PE, if it's not if the patient are not in the unstable condition, usually they come back very quickly, and everyone will be happy you saved their life. David, this was the case today. What do you think?
Thank you very much, Joseph. This is mind blowing, and again, so reminds me of the complexity of diagnostic reasoning, and the reason why we always need to come back to come back to reading every single time. So there's this case that I shared with you in the past of a patient. I made a diagnosis of PE from history and ECG. There was no CTPA because it was sort of an outreach, and the unfortunate fate of that patient because of delays after a referral to go to a center where they could manage her properly. And again, reminds me of another patient that I saw, not an exactly similar presentation, but so it was a presentation that you basically could see changes that are in keeping with with an acute coronary syndrome with the T segment changes. And then for that patient, both troponins and D dimer were very much elevated. So basically, I just wrote both diagnoses, and so an acute myocardial infarction and then pulmonary embolism, and referred the patient to JKCI. And so they did investigations, and so one of the things that they ended up doing was a CTPA, and it turned out to be pulmonary embolism and not a myocardial infarction. And if I shared the ECG of that patient, you would see it and say, this is an MI. So uh, it's very interesting things. And I think this just reminds me that when you see this presentation of dyspnea and this constellation of symptoms, you see dyspnea, you see palpitations, and these symptoms, I think it reminds me that I have to come back to the at least litho 6, or you can go up to 12 basically, to make sure that you rule all of them out before you think of other things. So out of those, an acute coronary syndrome is one, and pulmonary embolism is another one. So if I went back, I think an incomplete look at the ECG, because I talked about pathological Q waves. I did not remember to look at them initially, although I pointed out later that I would need to look at that ECG in order to see if there are any pathological Q waves. But then probably even if I saw them, I would say, okay, the pathological Q waves are again explanatory of an acute myocardial infarction, and therefore I think that biased me in the direction of an I mean, for ischemic heart disease particularly. So the normal troponins, I was not concerned for an acute myocardial infarction, but I was thinking of ischemic heart disease in general, including something like a stable angina. But then because the patient is diabetic, may be difficult in breathing rather than chest pain. So I think it's been huge teaching for me. And so yeah, I think that goes to the at the back of my mind. So when I see cases like this next time, I also remember to think that pulmonary embolism, maybe a one liner would be pulmonary embolism is a very good MI mimic, or ischemic heart disease mimic, and therefore it's very
Yeah,
easy to mix the two. So thank you very
exactly.
much.
Exactly.
Yeah,
Yeah,
so
thank you.
we are beyond the hour, but I saw the chat was busy, Lamek as well as Fabian. So pathological Q waves, and so the help was right here. Lamek pointed it out, pathological Q waves in lead 3. But if I could have caught this on time, maybe it would have changed some things. So thank you, Lamek, for the help. Unfortunately, I didn't pick it on time. And all the yeah, so Fabian and Lamek were very active here. Thank you very much. Now, is there anyone with just some quick comments, whether it's questions, comments, or sharing experience before we close the session? Yes, I see a hand from Sizu. Please welcome. Can unmute.
Oh,
Yes.
okay. Thank you so much, Joseph and David. It's one of very interesting case. Initially, when we were going through the path of the diagnosis, I was on the same track as David. After seeing the ECG and the clinical presentation of a patient, I've never thought of PE. And this came to me because of recent we've noticed a new guideline from American Heart Association 2026 on the diagnosis and management of patients with pulmonary embolism. So I didn't know why Joseph strictly go to CTPA for a patient who had ECG showing some features of TOF's inversions with negative troponin, instead of doing the dimer and Rick classification if he was thinking for PE. I didn't get the reasoning behind, because it was straightforward for him from ECG to CTPA. Because if you go back to the algorithm of diagnosis of pulmonary embolism currently from American Heart Association, they need us to stratify patient before going to CTPA. And they're saying a basic validated tool like Wells score can predict patients who will necessitate CTPA. And some new diagnostic tools such as VScan and others have been talked a lot from that guideline. But it was interesting because normally we see patients P with tachycardia. But from the initial vitals, this patient had a normal heart rate. We didn't see heart tachycardia. And as you said, Dr. David of recently, that maybe there's some sort of mimicry between patient with the MI with the PE. But all in all, it's a very interesting case. But my question was on the management of this patient. Why did we go direct to enoxaparin and not direct oral anticoagulation? What was the reasoning behind it? Because this patient had normal BP. There was no any cardiac pulmonary involvement in terms of hypoxia or shock. That's why we should go to maybe low molecular heparin. And so I want to get the reasoning behind why you started enoxaparin before these other drugs. And on top of that, I think this patient, Dr. Joseph, will benefit from angel. If there is a real light-sided involvement and troponins are negative, but we see T waves inversion, still we have something to question about it. Just my thinking around it. Thank you.
Yeah, thank you very much, Dr. Sizwe Bondo. Yeah, there is a problem with what is called the what did you ask? You asked about the
My question was, what was the reasoning behind from ECG to CTPA? That's number one.
oh yeah,
And other thing is on the management of patients PE.
sure,
Why did
sure.
you go for enoxaparin before
Yeah, thank you. So let's start with why I didn't do the D dimer. So the D dimer that is paid, this patient has an NHIF. There is something called fibrinogen something product slash D dimer, paid 8,000. We don't know if that is a real D dimer. I know it when I send for every patient, it's usually high, high, high. I did it. It was also high. I didn't want to include it here because if you go to JKCI, what they do is it's not this. You have to pay for cash, something 50, 100, 50K, the real D-dimer, which is raised. So this fibrinogen degradation product is not it. That's we have for NHIF. I didn't include it. I did it. It was also raised, but it's usually raised for every other case. Why I used enoxaparin, so you can choose. It's the same. If you can decide to choose enoxaparin or rivaroxaban in a patient who is stable, like this patient. But yeah, so real life, I saw this patient. I was in between what was happening. I saw the pulmonary, the CTPA. I said, I think this is PE, but let's wait for the radiology. So you have to admit this patient. You cannot tell the patient go back home with this rivaroxaban, and then the radiologist tells me there is nothing like PE. So if she's in the ward, I opted to give Clexane instead of rivaroxaban. I haven't seen the 2026 guidelines, but when you open up to date, what comes up there is that the change in management, the change in management that you categorize now in groups, and there are groups that you say medical management or straightforward to reperfusion therapy. And yeah, something else, PEs, my friend, can be tricky. David knows that I presented the case for him before syncope, and then it was PE. If you say that we do maybe wells in that patient, wells might be low, maybe. Yeah, that's it. I don't know if I've answered it.
Yeah, so
Yeah.
another thing that I remembered, which I commented on initially, but then I did not take forward to when I was presenting this problem in my mind, was the oxygen saturation of between 92 and 95. So again, I know that in our setting particularly, we start to get very much worried when the saturation is below 90, but then a saturation of between 92, something below 95, is not really, I mean, is not something that we commonly, in a patient who is not hypoxemic, you do the oxygen saturation and it comes something 90, 98, 99. So the 92 to 95, I think I talked about it initially and then I did not carry it forward. So I think there was, even if it's mild, but there was some hypoxemia in this patient. And yeah, so Joseph, yes, are we? Do we have anything else before we close? Because the discussion and Caesar, do you have any other thing that anything else that you liked that you wish to share before we move on?
Yeah, maybe something a little bit to share on this case because on my setting, most of time of this week, we had one case of PE, and it was kind of tricky as this patient, but eventually we managed to do CTP and found this patient had PE. So one of my senior doctor around, he gave me this a new handout of American Heart Association Management of PE and the classification of patients with PE. So on part of management is kind of different right now. I don't know if it is direct applicable to all of us around, but this now patient have been categorized whether this patient could fall in category A to category. So in terms of management, I think it changes for a patient with incidental finding of P. As to this case, initially this patient was not directly showing this is P. Even the doctor who saw him initially, he didn't think this is P. Then he did CTP and for there's a P. So they are recommending a different path on management. So my comment is I don't know if we can apply to this type of patients, but they are saying now we need to change the way we approach in terms of management, in terms of those categories. So that's it, Dr. David. But thank you. It's a very mind-blowing case. And thank you, everybody, for sharing. Thank you, Dr. Joseph, too, for your insights.
Thank
Yeah,
you very
but
much.
Caesar, this was
Yes.
not incidental. Incidental is the, let's say you have a patient with cancer, you have to see if they have mets in the lungs. There is no complaint whatsoever, and they are walking. You do CT chest, maybe with contrast. You see a PE. You say that is incidental PE. But this patient was normal, and 4 days ago started feeling shortness of breath with exertion, plus palpitation, plus the oxygen is dropping, and this is symptomatic, and these are symptoms for PE. So this was a PE. This category is she's stable. She won't be in the C or D category. She will be in the stable category that you give Clexane or rivaroxaban and not reperfusion.
Yeah. So thank you very much, Joseph and Caesar, for the very interesting insights. I see another hand from Fabian. Please welcome. Fabian, you are muted. If you just unmute and speak. I know we are beyond time, but then we cannot let this education today pass. So please allow us to take a few more of your minutes. Fabian, please welcome.
Yeah, thank you very much, actually, Dr. Joseph and Dr. David. It was actually a very nice presentation, very insightful, actually. I didn't even think of PE at this moment. I was just wanted to highlight on the new guideline that has been released by HA and CCA. So I think it's a very good guideline, actually, it's trying to stratify patients. But I think with our local settings, I think also logistics, uh, it's something that we should look at, because sometimes when you do CTPA, sometimes take a long time to get the results out. And actually, the other thing that Dr. Joseph has already highlighted, this was not incidental. So managing as an inpatient was the right track according to the new guideline. Thank you. Just two things to highlight.
Thank you, Fabian. So I I do not see any other hands. Caesar, your hand is still up. I'm not sure if it was the previously raised hand or if there's anything new. Caesar, are you there? Okay. So apart from Sizwe, I do not see anyone else. So if there is nothing else, thank you very much, everyone, for joining today. I think this has been very educational. I also saw Upendo in the chat. The chat was very active today. So thank you very much, everyone, for joining and for sharing your experiences and insights. We yeah we won't be having a session next Sunday, because next Sunday will be Easter. As because these are holidays, we try to make sure that everyone gets time to celebrate with family, to relax. So we'll meet here in 2 weeks. After next weekend, we'll meet the week after, and then we'll continue with education. So thank you very much, everyone, for joining and for sticking around this long. We hope to see you. We hope to see you after next week, and have a good night.
Good night.